Kanya-kanya.
Just water എടുക്കാം.
Hello, HF. ഞാൻ ഇതിന് ചുമ്മാ മീറ്റിംഗിൽ ഒന്ന് കയറി നോക്കിയതാ എന്തെങ്കിലും കാണിക്കുന്നുണ്ടെന്ന് അറിയാൻ. ഇവിടെ വെറുതെ വെച്ചിട്ടേ ഉള്ളൂ, സൗണ്ട് കുറച്ചിട്ടേക്കാം. നമുക്ക് ആരെങ്കിലും ഉണ്ടോ നോക്കാം. ശരിയുണ്ട്.
Good evening, everyone. Myself Vignesh, Dental Students Association Kerala President ആണ്. DSA കേരളയും ഐഡൻ ടു ഡെന്റൽ ആപ്പും ചേർന്ന് നടത്തുന്ന ഒരു ഫ്രീ റിവിഷൻ സീരീസ് ആയിട്ടുള്ള ദ ഫൈനൽ പുഷ് ഇന്നിവിടെ സ്റ്റാർട്ട് ചെയ്യുകയാണ്. OMFS ക്ലാസ്സസ് ആണ് ആദ്യം നടക്കുക. ദ മോസ്റ്റ് എഫിഷ്യന്റ് ഫാക്കൽറ്റി വൺ ഓഫ് ദ ഓതർ ഓഫ് ഡെന്റൽ പൾസ് ബുക്ക് ശ്രീ ഡോക്ടർ ബാബു സാർ ആണ് നമുക്ക് ക്ലാസ്സസ് എടുക്കുന്നത്. ഹോപ്പ് ഇറ്റ് വിൽ ബി വെരി യൂസ്ഫുൾ ടു എവരിവൺ.
ശരി, ഞാൻ വിളിക്കാം.
ക്ലാസ് ഒരു 10 മിനിറ്റ്സിൽ സ്റ്റാർട്ട് ചെയ്യും. ചെറിയ ടെക്നിക്കൽ ഇഷ്യൂസ് ഉണ്ട്, അതുകൊണ്ടാണ്.
ഹലോ ഫ്രണ്ട്സ്, ഞാൻ ഇസ്ര, DSAയിലെ വൈസ് പ്രസിഡന്റ് ആണ്. ഞാനൊരു പാർട്ട് 2 ഇപ്പം എക്സാം കൊടുക്കാണ്ട് MA ജനറൽ കോളേജിൽ പഠിക്കുന്ന ഒരു വിദ്യാർത്ഥിയാണ്. ഇപ്പം നമുക്കറിയാം, ഈ നിൽക്കുന്ന എല്ലാവർക്കും 14 ദിവസം കഴിഞ്ഞാൽ എക്സാംസ് ആണ്. എക്സാമിന് എന്ത് ചെയ്യണം എന്നറിയാണ്ട് നമ്മൾ ആകെ എന്താ പറയാ, ഒരു വല്ലാത്തൊരു സ്റ്റേറ്റിലാണ്. കാരണം പ്രോസ്തോ നോക്കിയാലും OMFS നോക്കിയാലും അതേപോലെ കൺസേർവ് ആവട്ടെ, എൻഡോ ആവട്ടെ, പീഡോ ആവട്ടെ, അങ്ങനെ എല്ലാ സബ്ജക്ട്സ് നമുക്ക് കവർ ചെയ്യാൻ പറ്റുമോ, എത്രത്തോളം കവർ ചെയ്യണം, ഈ പോയിന്റ് വിടാൻ പാടോ, ഈ ടോപ്പിക്ക് വിടാൻ പറ്റുമോ, ഈ ടോപ്പിക്ക് നമ്മൾ പഠിക്കണം എന്നുണ്ടോ, ഒരു ഐഡിയ കിട്ടില്ല. ബിക്കോസ് ഒന്നാമത് 6 months കൊണ്ട് നമ്മൾ എന്തൊക്കെ ഒരു മാരത്തൺ റൺ ഓടിയിട്ടാണ് പാർട്ട് 2 തീർക്കണത്. അതിനോടൊപ്പം ഇന്ന് ഏകദേശം ഒരു ഡേറ്റിനെ പറ്റിയിട്ട് അറിഞ്ഞിട്ടുണ്ടാവില്ല, പ്രാക്ടിക്കൽ ഡേറ്റ്സും ഭയങ്കര ക്ലോസ് ആണ്. അപ്പൊ എല്ലാം കൂടി നമ്മളാകെ ടെൻസ്ഡ് ആയി നിൽക്കുകയാണ്. കോട്ട തീർന്നിട്ടില്ല, പേഷ്യൻസിനെ കിട്ടണം എന്നൊക്കെ പറഞ്ഞിട്ട് കോളേജിൽ നിന്നുള്ള പ്രഷർ വേറെ. അതിന്റെ കൂടെ ഈ OMFS, എസ്പെഷ്യലി OMFS സബ്ജക്റ്റിനെ പറ്റി നമുക്ക് യാതൊരു ബേസ് ഇല്ലാത്തൊരു സബ്ജക്റ്റാണ്. പലർക്കും എങ്ങനെയാണ് ഒരു എക്സാം, ആ ഒരു ടോപ്പിക് അറ്റംപ്റ്റ് ചെയ്യേണ്ടത്, അല്ലെങ്കിൽ എങ്ങനെ ഒരു എക്സാം എഴുതേണ്ടത്, എന്തൊക്കെയാണ് ഇൻക്ലൂഡ് ചെയ്യേണ്ടത് എന്നുള്ളത് എനിക്കടക്കം ഇതുവരെയായിട്ട് ഒരു ഐഡിയ കിട്ടിയിട്ടില്ല. ഡോക്ടർ ബാലാസർ MA മലബാർ ഡെന്റൽ കോളേജിൽ HOD ആണ് OMFSലെ. സാറ് പേഴ്സണലി സാറിനെ എനിക്കറിയാം. അപ്പൊ സാറ് എത്രത്തോളം എന്താ പറയാ, സാറിന്റെ വിസ്ഡം നമുക്ക് തരും എന്നുള്ളത് എനിക്ക് നല്ല ഉറപ്പുണ്ട്. കാരണം സാർ അത്രയും നന്നായിട്ടാണ് സാറിന് നമ്മൾ പേഴ്സണലി കാണുമ്പോൾ ഒക്കെ സാർ ഭയങ്കര കാര്യമായിട്ടാണ് ഓരോ സബ്ജക്റ്റിനെ പറ്റി നമ്മളോട് പറഞ്ഞു തരിക. അപ്പം ആ ഒരു സാറിന് നമുക്ക് ഈ എക്സാമിന് വേണ്ടിയിട്ട് ഒരു നല്ലൊരു റിവിഷൻ ക്ലാസ്, ഇപ്പൊ നമുക്ക് ഈ ഒരു 1.5 മണിക്കൂറും കൊണ്ട് കൂടുതലൊന്നും പറയാൻ പറ്റില്ല. പക്ഷെ എന്തൊക്കെ ഒരു എക്സാം എങ്ങനെ അറ്റൻഡ് ചെയ്യണം, എന്തൊക്കെ കീ പോയിന്റ്സ് യൂസ് ചെയ്യാം, എന്തൊക്കെ നമുക്ക് എഴുതി പിടിപ്പിക്കണം, എന്തൊക്കെ വിടരുത്. ഇപ്പം ചിലപ്പം ചില കാര്യങ്ങളുണ്ടാവും, ടിപ്സ് ആൻഡ് ട്രിക്സ് അവർക്ക് അറിയണത്. അപ്പൊ അതൊക്കെ അവർ നമുക്ക് സാർ ഇൻഷാ നമുക്ക് ഷെയർ ചെയ്ത് തരും. അപ്പം അതെല്ലാം നോട്ട് ചെയ്ത് നമ്മൾ ഭയങ്കര എന്താ പറയാ, ഭയങ്കര ക്ലിയർ ആയിട്ട് അറ്റൻഡ് ചെയ്യുക ക്ലാസ്. ഒരു മിനിറ്റ് പോലും വിടരുത്. കാരണം ഓരോ പോയിന്റ് ഹലോ, സോറി, നെറ്റ്വർക്ക് ഇഷ്യൂസ് ഉണ്ടായിരുന്നു. സോ ബേസിക്കലി ഞാൻ പറഞ്ഞു വന്നത് നമ്മൾ 4 ദിവസത്തെ ക്ലാസ് നല്ല രീതിയിൽ അറ്റൻഡ് ചെയ്യുക. നമുക്ക് ഓരോ പോയിന്റും അവരിപ്പം ഈ 4 ദിവസം കൊണ്ട് നമുക്ക് ഒരു എല്ലാ സബ്ജക്ട്സും എല്ലാ പോയിന്റും എല്ലാം നമുക്ക് പറഞ്ഞു തരാൻ പറ്റില്ല. പക്ഷെ കീ പോയിന്റ്സ് പറഞ്ഞു തരും, എങ്ങനെ എക്സാം അറ്റൻഡ് ചെയ്യണം എന്ന് പറഞ്ഞു തരും, എക്സാം എങ്ങനെ അപ്പിയർ ചെയ്യണം, എങ്ങനെ പ്രസന്റബിൾ ആക്കണം. ഇപ്പൊ അഥവാ നമുക്കൊരു ക്വസ്റ്റ്യൻ അറിഞ്ഞില്ല തന്നെ വരട്ടെ, അതെങ്ങനെ നമ്മൾ ഡീൽ ചെയ്യണം, എങ്ങനെ നമ്മൾ ക്രാക്ക് ചെയ്യണം എന്നുള്ള കാര്യങ്ങളാണ് ബേസിക്കലി ഇവർ ഇപ്രാവശ്യം പറഞ്ഞു തരിക. അപ്പം ഓരോ കാര്യങ്ങളും നല്ല വൃത്തിയിൽ കേൾക്കുക, അത് ഇംപ്ലിമെന്റ് ചെയ്യാൻ ശ്രമിക്കുക. ഇവരെ പാട്ട് ചെയ്തു തരും, ബാക്കി നമ്മളെ പാട്ടാണ്. ആകെ കുറച്ച് ദിവസം കൂടി ഉള്ളൂ നമ്മളെ ഡ്രീം ട്രൂ ആക്കാൻ വേണ്ടിയിട്ട്. സോ മാക്സിമം എഫേർട്ട് ഇടുക. ആ എഫേർട്ടിന്റെ നല്ലൊരു ഔട്ട്കം നമുക്ക് എല്ലാവർക്കും കിട്ടട്ടെ, സാധിക്കട്ടെ എന്ന് പറഞ്ഞുകൊണ്ട് ഞാൻ നിർത്തുന്നു.
തുളസിദാസ് വരാം. എല്ലാരും ഉണ്ട്, നീ മാത്രം കേറാത്ത.
Guys, we are facing a technical issue at Balancer's end, so we'll be starting the session very soon. Sorry for the delay.
Yes, hello everyone. Good evening. Very, very sorry for the technical delay. Still, you students are there. Good. So, first of all, am I audible? Please put it in the chat box. Am I audible? Yes, no. Please put it in the chat box. Am I audible or not?
Yes, sir.
Can anyone confirm?
The voice is not so clear, sir.
So hello students, first of all, I would like to know I'm audible or not. Some technical issues are there which is beyond our control. So we're trying to work on it. If you can put it in chat box, go ahead. Okay, so I think I'm audible. I will start the session. Extremely sorry for the technical glitches. Okay, so students, so your time has come now. You're just few days away from your exams. Hardly 30 you have in your hand. So this is a very, very crucial moment. You need to really put in a lot of hard work, and then only things will happen. Just a second. Yes. So, first thing first, exams without anxiety. Impossible, is it? See, we have written so many exams from first BDS, second BDS, third BDS. Every time during the exams, tension will be there, anxiety will be there. Yes or not? So before the start of preparation, all of us are like this. All of us are like this. Very fresh, energetic, with a lot of hope that we will study very well. And during the process of our exam preparation, towards the end, we become something like this. Tell me honestly, is this correct or not? This is the story of all of us, right? So this happens because of unorganized way of preparation. So today, in a nutshell, I will explain you in between the topics what all needs to be done in the next 13 days. You are at the beginning of the examination summit. Your BDS career is going to come to an end. What you started with LKG, UKG, this is the final 13 days for your theory exams. After this, there is no mandatory exams for you. If you want to do MDS, that is an optional, but there is no mandatory exam. There are no vivas. There are no internal exams. So it is an exciting thing which is going to. Lowering the arch. Okay, I hope there will be no interruption from now onwards. Right. Okay. So dear students, I'll just straight away start with the first question of the day. That is our gate control theory. So I want all of you at your very best, right? So these technical issues were not in our hands. Extremely sorry for that. So we always have a mentality, let these exams go, I will study seriously for the next. But you are in part 2, there is no next. This is the only time you have, and the next 13 days is extremely crucial in your life. So let's start now and get into our first question, that is gate control theory. Okay, this gate control theory is a theory in the pain, it comes in pain, the pain pathway and all, it comes there. So this is a question which is of 5 marks. Okay, 5 marks value it has. And this is a question which many students miss around. Many students miss around. Why? Because they will study in the local anesthesia. So first thing is gate control theory. Just a second, I would like to know whether the slides are changing or not. Are the slides changing?
Yes, sir.
Okay. Right. So all of your friends who have just left out, please tell them to come back, because this is the moment you have to learn. And to control, to study this gate control theory, I'll tell you, when I was in part 2 BDS, I did not know even a single bit of it. During my PG course only, I learned what is this gate control theory, to be very honest. Right? So this gate control theory you will get in the book of Monims. All the diagrams what I am going to show, it will be from Monims. Okay, so let's start now. Gate control theory. Now, look at this diagram, this photograph. So what do you see in this photograph? There are 2 trains. Okay, the train number 1, what you're seeing here, left side, where the cursor is moving, it is the pain train, pain. The second one is the happy train, happy train. So both the trains are there. Now the brain is the railway station. The brain is the railway station. Now, is it possible for both the trains to reach the station or the brain at the same time? Impossible. 2 trains cannot travel at the same time at the same track. That is not possible. So now it is the duty of the gate man who is sitting there to allow one train first, and then the next train he will allow. You can't be happy and sorrow at the same time. You got a hit, it's paining. I got a hit in my hand, it's paining. So I'm feeling the pain. Same time, I got some 5,000 rupees. I'm very happy for that. But I cannot be both happy also. One eye I am happy and one eye tears are coming. That is not going to happen. So this is not going to happen. Why? Because only one signal will reach the brain. So who controls it? This is the gate man. So this gate man is the one who will say, stop. I will determine who will go to the brain first. So this gate man will stop the trains, and then according to the stimulus, according to the intensity, it will allow. Please remember this diagram. In next 5 minutes, towards the end of this gate control theory, I will tell you the whole story, and I will tell you, remember this diagram again. So this, please take screenshots also if possible, right? This diagram is extremely important. Towards the end, we will reach the same diagram. Okay. Now, so this gate control theory was proposed by Melzack and Wall. This the pioneers in that. Basically, this is a psychological mechanism. Psychological. I lost a mobile phone. This is fearing for the where is my phone? That is a psychological mechanism. I want all of you to mute, please. Can you all mute yourself? Yes, that's fine. Again, some. Please mute. Yes. So this gate control theory was given by Melzack and Wall. So this is the first line you will have to write. The second concept is, what is it? It is a psychological mechanism. I lost my phone. It is a psychological thing. I broke up with my girlfriend. This is a psychological thing. So I am just sitting and thinking about the memories. So it is hurting me more. It's giving me more pain. Right? So it is a psychological. But after some days, everything is fine. I am back to my normal life. So it is a psychological mechanism. Gate control theory, psychological mechanism. So the gate man, what you saw, it will modulate, it will open and close the gate. According to that, the pain will be modulated to the brain. Okay. Now, so these gates, where are they situated? I get hit in my leg, in my hand, in my head, anywhere part of the body, I can get a hit. But where are these gates located? So please understand, these gates are located in the spinal cord. Spinal cord. So all the pain stimulus will come to the spinal cord, and from there, the gate will decide which pain has to go to brain. Example, candle, there is a candle and my hand is getting burned. So one stimulus is going, your hand is getting burned. At the same time, someone comes and slaps me, a huge slap. So now what happens? This slap intensity is more, and it is more towards the brain. This I will feel more pain rather than the candle which is burning my hand. So this spinal gate, these gates are located in the spinal cord. So what I told till now, Melzack and Wall are the pioneers. It is a psychological mechanism. These gates are located in spinal cord. Now spinal cord, these gates, what they will do? It is like your college principal is there. There will be a PA to principal. Now anything happening in the college, the PA to principal will inform the principal. So the position of the PA is very important. They can exaggerate and tell any matter. Oh sir, you did not know yesterday evening what happened in the library. Just exaggerating and telling. Or it will take out, even though big thing happened, it will remove all the crucial information. No sir, some fight was there. There's nothing big sir. It is a very simple thing. So it can add, amplify the impulses, or it can reduce the impulses. Or it will not tell the principal only. The PA will not inform the principal only. So similarly, the gates in the spinal cord will allow the information to pass directly to the brain. One, directly to the brain. Second, it will alter. It can amplify. It can increase or decrease the intensity of the pain. Third, or it will stop the impulses reaching the brain. So only you have got 4 options. It will pass directly. It can increase. It can decrease. It can prevent. So these are the functions of the spinal cord, where gates are situated. I will come which location in the spinal cord, I will come further. Right. So please remember, it's a mnemonic like same, S-A-M-E, same. S for sensory, A for afferent, M for motor, E for efferent. Okay. So this is a mnemonic, same. So sensory nerves are also called as afferent nerves. And the motor nerves are also called as efferent nerves, efferent nerves. So that is why you see this chart which is there in your left hand side. So whenever there is a stimulus, you get an injury, the nociceptus gets activated, the sensory fibers will carry the information, it will go to spinal cord where your gait is there, and from in the spinal cord, it will travel to the dorsal horn, substantia gelatinosa, these three are there in spinal cord, and from there it goes to the brain, your pain pathway. Then later it becomes the pain pathway and it goes up. So just remember, same, sensory means efferent, motor means efferent. So if I'm calling efferent nerves, that means sensory nerves. The most important part of gait control theory is here. Now, whenever there is an injury, someone slaps you, right? One cricket ball came and hit you, you fell down, something happened, you banged the wall, whatever injury. The first, whenever there is an injury, A delta and C fibers gets activated. So I slapped myself. The fibers which getting activated are A delta and C fibers. What are these fibers? Small peripheral fibers, small peripheral nerves, you can call it. So you can take a screenshot of this slide. It is extremely important. A delta and C fibers are injury nerves. Okay. So from here, the information is carried up. Then you have got A beta fibers, which is large peripheral nerves. So please remember this slide. So whenever there is an injury, A delta and C fiber gets activated, and large peripheral nerves, A beta fibers. Now you see a cricket match or a football match. Whenever the sports person, the player, they get injury, they fall down, the physiotherapist will come and he will massage that area. He will rub that area. So once he rubs that area, what happens? A counter stimulation happens and the player does not feel the pain. And he plays within few minutes, he is ready to play in the ground. So that is the mechanism what we are going to discuss right now. So whenever there is an injury, see bracket I have written injury, A delta and C fiber gets activated, and the pressure when you massage that area, A beta fiber gets activated. So I hope the concept is very clear. Is there any doubt till here? You can please unmute and tell. Rather than chat box, just unmute and again mute yourself and please tell. Okay. So A delta and C fibers are small peripheral nerves, and then large peripheral nerves are A beta fibers. This, I think it's very clear. Please take a screenshot. The whole story revolves around them. So whenever there is an injury, small peripheral nerves, that is A delta and C fiber gets activated. And when you massage that area, large peripheral nerves, that is A beta fibers, get activated. So that concept is very clear. Now see this. A hammer, if you hit the nail with the hammer, what happens? You get pain in your finger. So which fibers? A delta and C fibers gets activated. So once you hit the hammer, once you hit with the hammer your finger, or someone by mistake it has happened, what do? You rub that finger, right? So you rub that finger. So counter stimulation is there. This you see in the physiotherapist doing in cricket ground and football ground also. Counter stimulation happens. So when there is an injury, A delta and C fibers get activated. And when you counter stimulate, A beta fibers gets activated. So A delta and C fibers, the previous slide, they are small peripheral, and A beta are large ones. I hope the concept is clear. So that is how the counter stimulation, when a physiotherapist comes and does, the patient does not feel pain. Now see what happens. So same example I will use. The nail, the thumb has been hit by a hammer. So once it happens, the A delta and C fibers, you can see here, A delta and C fibers gets activated and they go into the spinal cord. The green color line, what you're seeing, green color dot, 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 what you're seeing, A delta and C, because of the injury. Someone slapped you, you fell down, whatever injury, A delta and C fibers goes to the spinal cord. And then you rub that area, counter stimulation you do. So with that, what happens? Your A beta fibers gets activated. That is this blue color line. This blue color line comes here. Now I told you I showed you one photograph in the beginning of gait control theory. Two trains coming at the same spot. Do you remember that? Same thing. See here. This is one blue color and this is green color. One is A delta and C fibers, which is injury or pain, and the green one is A beta fibers or pressure or massage what you have done. Both of them reach here. Now the magic starts. Now see what happens. Same thing, A delta and C fibers, when injury comes, just see the slide very properly. This yellow color, what you are seeing, they go there. I hope it's very clear. So it has reached in the spinal cord, substantia gelatinosa. And when you counter stimulate, see this pink color arrow mark, it also goes at the same spot. So both of them are at the same spot now. Now what is happening here? So A delta fibers, C fibers, which has come through this green arrow, yellow arrow, and for the pink arrow, that is your beta fibers have come, both at the same spot. Now the gate control theory comes into action. Now see what happens. This is the most important part. If you learn this, the gate control theory is over. Now see this. You see A delta and C fibers reach here. I'm talking about this box. This box, this is substantia gelatinosa. Right? Your first order, second order neuron transformation, they take place here. So A delta and C fibers comes here and they reach this part. At the same place, A beta fiber comes from above. A beta is the massage, what you do, that fibers. A delta and C are the injury fibers, pain. So what happens? A beta fibers, they give a collateral branch. Please understand now. A beta fibers came like one, and once it reached this area, now I have my two hands. So I spread out.
Please allow.
I spread out. I spread out. See here. So this A beta fibers give two branches. One branch comes like straight, and this will block the A delta and C fibers which is coming from down. I hope it's very clear. Please make a note of it again and again. A beta fibers comes like this, and then a collateral branch is there, and this collateral branch, one branch comes straight over here, and this collateral branch of A beta fibers will engage the A delta and C fiber, that is the pain fibers here. So what happens here? The neuromuscular junction gets delayed. The neurotransmitters do not come into action, and it is blocking this area, whereas the other collateral branch directly goes to the brain. It is just like playing a musical chair. Or musical chair, what we do, we run around a chair, and once the music stops, we will try to stop the other person and go and reach to the chair sometimes. So with one hand, I am blocking the C fibers and A delta fibers, and with the other hand, I am going towards the brain. So what happens? The pain, what you had, the injury, what you had, it is not able to go into the or cross the neuromuscular junction. It is not able to propagate. Whereas A beta fibers collateral branch will block, and the other one, the massage will go up, so you feel a soothing effect. This is your gate control theory. That's it. So actually what happened? What happened actually? Nothing big. This is the same photograph what you're seeing. This happened. So this is your A beta fibers. Shah Rukh Khan is your A beta fiber. It will go and catch the A delta and C fibers. Whereas with the other hand, it will connect to the brain. So this photograph clearly depicts the gate control theory, right? So same thing what you have studied here is this one. So this is your neuromuscular junction, how it propagates. Please make a note of this. So this is the pain fibers, A delta and C fibers, which has come here. So now the fibers have to cross, and then it has to reach the brain. But what happens at the same time? So here neurotransmitters will be there, glutamate and substance P will be there. So with the help of them, this A delta and C fibers, it will take the pain impulses and it will transfer. But what happens at the same time, this is the place where the magic takes place. And what is that magic? The A beta fibers will come, it will give collateral branch, one branch will engage with this. So both of them are fighting with each other. So this propagation or impulse travel is not happening at that speed. At the same time, when it is engaged in fighting, one fiber will, other collateral branch will go and hit the brain. So what happens? Because of the time delay, calcium influx gets blocked and no neurotransmitters are generated here. This glutamate and substance P are not generated. So the pain impulses do not travel to the next nerve fiber and it does not reach the brain. So this is delayed and brain is getting the counter stimulation. So that is what happens here. Now see this diagram I have taken from Monim's book. Monim's. Okay, in management book it is not there. Similarly, you've got whenever there is an injury, slow fibers, A delta and C fiber. This diagram you should draw in the exam. Okay, so slow fibers, A delta and C fibers are there. So whenever there is a stimulus, it will go to the substantia gelatinosa and thalamus. But when you do counter stimulation in that area, what happens? It will bypass this. I told you there will be collateral branches and one branch will go and engage A delta and C fiber, other branch will reach the brain. So same thing you see here. So this A beta fibers, it is bypassing, just like the bypass road of your city. It does not enter the city. It does not enter the city. So this is the town, you imagine like that, where a lot of traffic jam is there. So this counter stimulation, A beta fibers will just bypass and it will reach the brain. It reach the brain. Please mute yourself. I request all of you to mute your.
Meeting is being recorded.
Please mute yourself. I do not want to call the names. Yes. So small fibers, they reach here and they get blocked. So this diagram is extremely important. Now, what are the factors which involve opening and closing the gate? So it is the gate control theory, the gate which is there in substantia gelatinosa in the spinal cord, which determines. First is what will decide whether the gate will open or not? The amount of activity in the pain fiber. Who is stronger? Whether A beta fiber is stronger or A delta and C fiber is stronger. Who is stronger? That will reach the brain. Amount of activity in other peripheral fibers also. And messages that descends from the brain. So these are the three factors which will open and close the gate. Now, conditions that open the gate. So that means you get pain very fast. See, there are, for example, there are two students. Both of them got 34 marks. In the internal exam, both of them got 34 marks. One student is very depressed and crying, but the other student is very normal and happy. Same marks, but different reaction. So, sensitivity level. So the conditions that open the gate, first is the physical condition. So physical condition means extent of injury, how hard you have been hit. And inappropriate activity level. So it depends from person to person. Emotional conditions. If you are tensed, you are worried, then the pain intensity increases. You miss your friend, you lost your mobile, the withdrawal of that, like breakups in love affairs and all. So that withdrawal gives more pain. Always thinking about that. And mental condition, always focusing on pain. I lost my phone. I lost my friend. I lost this. I lost that. So focusing on the pain increases. And boredom also. Whereas conditions that close the gate are the physical conditions. I am having headache. I take a painkiller. My headache gone. So counter stimulation. You do a head massage. The pain gone. Emotional conditions. If you're having pain, take positive emotion, relaxation, rest. Time will heal everything. So these are the things which will close the gate. And mental conditions like distraction. Completely worried, go for a movie, change the topic, you feel better. So these are the conditions that open and close the gate. So this is one MCQ. Gate control theory of the pain is due to which of the four? Substantia gelatinosa, A dental fibers, C fibers, free nerve ending. Can you please answer if in the chat box? It will be great if you can answer this. Gate control theory is where in substantia gelatinosa, A delta fibers, C fibers, free nerve endings. Yes, very good. Excellent. All of you are answering. All are correct. Excellent. So the gate control theory is in substantia gelatinosa. So where is the substantia gelatinosa? This is there in the dorsal horn of the spinal cord. Dorsal horn of the spinal cord and nucleus of fifth cranial nerve. That is the trigeminal nerve. Trigeminal nerve nucleus, dorsal horn. That is first point. So this dorsal horn in the trigeminal nucleus is divided into 6 compartments or 6 laminae, we can call it. 1, 2, 3, 4, 5, 6. Out of 6, laminae 2 and laminae 3. This is the one where the substantia gelatinosa is the region. Right? So laminae 2 and laminae 3 is of particular interest for us. So the gate control theory is generally happening in substantia gelatinosa. Where is substantia gelatinosa? Dorsal horn of the spinal cord, nucleus, laminae 2, laminae 3. So that much if you write for gate control theory, it's more than enough. Right? So this is a theory which many people miss. They don't study and they lose interest because they don't understand. Right? So the concept is very clear. You get an injury, you're feeling pain, suddenly you start massaging that area, the pain goes off. Why? The A beta fibers will have collateral branches. One branch will take care of A delta and C fibers, and the other branch will carry impulses to the brain. Fine. So that was our first question. Second question, emergency drugs in dental practice. Very, very important. Right? Emergency drugs comes as a 5 marks question. After this question, I will be telling you about few exam tricks. So emergency drugs in dental practice. So I will be discussing the conditions and then what needs to be given over there. Because in your exams there is a time limit. You cannot answer in depth, right? Hardly a main question you can attempt for 20 to 25 minutes. A short answer for 15, even 15 minutes is too much. 15 minutes you can, and short answers for 7 minutes, short essays for 15 minutes. I'll break down that towards the end of the session. So emergency drugs in dental practice, the second question of the day. So these are the list of medicines, what should be there in your clinics, starting from atropine, diclofenac sodium, dexamethasone, morphine, glucose. So all these things I will be discussing where all it can be given. Then you need to have some injections, adrenaline, deriphyllin, dextrose, ranitidine, right? So all these names you should be remembering. Emergency drugs. So what are the conditions you can expect? You can expect syncope in your dental chair, in the dental office, angina pectoris, chest pain, myocardial infarction, epigastric pain, hyperventilation, diabetic coma, bleeding. So this is the one what you should write. Emergency drugs, if they ask, so what are the conditions where you will use the drugs? So you should write the drugs name first and the conditions second. Now the other conditions are, so this is first few, and then next one is adrenal crisis, thyroid crisis, cardiac arrest, foreign body aspiration, epilepsy. So almost like some 15 emergencies are there. So in this 15, even if you write 10 in the exam, it's more than enough. Just many people don't answer this question. I am picking only those questions which students do not answer properly. So let's start one by one at very fast rate. So once a patient goes into syncope, you know that, right? So this is an anti-Trendelenburg position. Make the patient lie down flat. Patient's heart and the brain should be at the same level, or the brain should be at the lower level, or elevate the leg so that the oxygenation and the blood supply to the brain is increased, which you know very well. Now, patient is feeling syncope or dizziness, and patient is feeling he's still conscious. If the patient is still conscious, then you give glucose powder, mix in glass of water, or just tell him to lick glucose powder, or spirit of ammonia. Spirit of ammonia bottle is there. Take a cotton and tell the patient to smell that. It acts like a respiratory stimulant. It acts like a respiratory stimulant. This is for those patients who are conscious. But the patient who are completely comatose or completely flat, they are unconscious, then they cannot eat glucose or spirit of ammonia also may not act over there. So in comatose patients, you have to give dextrose injection 25% IV. Please take a screenshot. Dextrose injection 25% IV. Extremely important. Intravenous line, you have to give dextrose. Patient will recover. This is for syncope patients. Next condition, angina pectoris. A patient is having chest pain during a treatment. So chest pain, it's all the chest pains are not heart attack. The chest pain could be due to various reasons. You need to identify and then give the medicines accordingly. So whenever there is a chest pain, first and foremost, give sublingual nitrate tablet. You take a tablet, put it below the tongue. Put it below the tongue of the patient, wait for 5 minutes. Right? So it is like just intramucosal, directly it goes to the heart. You can do maximum 3 times. The duration of 5 minutes, but you have to activate your medical emergencies. You have to call the doctor from the first minute onwards. Put a tablet and see whether the patient is recovering or not. If not, second tablet you can put after 5 minutes, third tablet you can put again after another 5 minutes. Maximum 15 minutes. After that, shift the patient to the hospital. So now our question is, angina pectoris, patient had chest pain, you kept sublingual nitrate. Pain relieved, very good. So you kept a sublingual nitrate tablet, pain relieved. So that is angina pectoris. Stop the procedure, tell the patient to go and show to a doctor. Now after giving sublingual nitrate tablet, putting it below the tongue even 3 times, pain is not relieved. Then it is a serious situation. Then it could be either myocardial infarction, aortic aneurysm, or gastric pain. So gas problem also can lead to chest pain. Okay, gas problem. So please understand that. Or it could be either MI, myocardial infarction, or gastric pain also. So this part we need to treat now. So it's very simple. There is angina pectoris, sublingual nitrate tablet, pain relieved, angina pectoris, confirmed. No problem. Stop the procedure, send the patient to hospital. Not relieved, it could be myocardial infarction or gastric pain. Now we will treat these 3 things. Myocardial infarction. So myocardial infarction, there is pain across the chest and patient is sweating so much and the pain is radiating to the left arm. That is the referred pain. Referred pain. Pain is radiating to the left arm. And myocardial infarction, why it have, how we told that it is myocardial infarction? Because it is not relieved by sublingual nitrate tablet. So not relieved by sublingual nitrate. So this is your condition and the diagnosis. Then what you need to do in myocardial infarction? You have to give some drugs. First and foremost, don't move the patient. Call the doctor. Give oxygen. Give oxygen to the patient and morphine injections, 5 mg slow IV you can give. And shift the patient to the hospital as soon as possible. Extremely important this is. This is for myocardial infarction. Morphine 5 mg slow IV. The other sublingual nitrate tablet you gave, pain is not relieved. It could be epigastric pain also. So this epigastric pain, the pain is at the abdomen area. This is your epigastric region. This region what you are seeing, this is the epigastric region. So here there could be a pain. So this is a gas problem, nothing else. This is the gas problem. So you need to give ranitidine injection over here. Ranitidine. Next condition, hyperventilation. So hyperventilation, suddenly a patient is feeling breathlessness. Patient cannot breathe. Right? And you try to give oxygen, still the condition is becoming worse. This is the problem. In hyperventilation, you should give carbon dioxide and not oxygen. So what you can do is, you can make a funnel. You can make a funnel with the paper and put it on the patient's nose and mouth. So the patient will breathe carbon dioxide and inhale carbon dioxide only. So give carbon dioxide, not oxygen. So this is all, I have made it like a flowchart manner so that it is very easy to write in the exams. Your presentation should be something like this. You can't go into the full story, definition, everything about hyperventilation, because this is a part of a question called emergency medicines and drugs and conditions. Next is diabetic coma. Patient is having diabetes and patient collapsed. Now what to do? You don't know whether it is patient is hyperglycemic or hypoglycemic. You have no idea. Patient just collapsed. So whatever patient is hypo or hyper, you give IV dextrose injection. IV dextrose injection 25%. This is the same thing what we gave in syncope also. So it is hyper or hypo, give IV dextrose injection 25%. Now you give dextrose injection, very good. Patient recovers. Two things can happen, either the patient recovers or patient does not recover. If diabetic coma, hyper or hypo, you give IV dextrose injection, and then if the patient recovers, it is hypoglycemic coma, because you gave dextrose, the glucose came, he was hypo, he became normal. So then if necessary, give glucagon injection. Even with dextrose 25% IV, if the patient does not recover, then it is hyperglycemic coma. Then you have to give insulin. So this is a flowchart which will help you to take a very quick decision, right? Patient, diabetic patient went into syncope, recovered, it is hypo, you give glucagon injection. Does not recover, still under syncope, it could be hyperglycemic, then give insulin injection, things will improve. So this is for diabetic coma. Next, in case of bleeding, if excessive bleeding is there, which you know what to do, it has been taught in your clinics also. So local hemostatic agents you can apply, ethamsilate, Surgicel, gel foam, even vitamin K supplement injections also can be given over there. Next condition, adrenal crisis. Now a patient, now for example, two people walking the stairs from ground floor to third floor. One person can very easily walk, but the other person is struggling to reach to the third floor. Same age group, but one is struggling and the other one is very easily going. This is because of the stress hormone is not equal in both of them. So it is the stress related crisis which is called adrenal crisis. So you know this, how adrenal gland works. Hypothalamus will dictate the anterior pituitary and it will tell the adrenal cortex to produce cortisol. So this cortisol is required for our daily stress maintenance. So whatever stress we are working here, they are walking, we need cortisol to balance that. Now, patient came to clinic, he wants an extraction to be done and he is telling, sir, I am already taking 100 milligrams of steroids. So what you should do, that 100 milligrams of steroid he is taking for his normal survival. And you are going to do an extraction, for that also stress will be there. So you double the dose. That means 100 milligram he is taking for his normal survival. Because he is taking 100, just before the procedure, you give another 100. It's not after the procedure or one day before and one day after. It is just before the procedure, you give the same amount of dose. So it is like double the dose. One he would have taken in the morning, one is before the procedure. So you have to give steroids here in adrenal crisis. Next, thyroid crisis. So there will be palpitations and tremors. So patient will have, and there will be tachycardia. Heart will go for a sixer, means it is tachycardia. So what you have to do in crisis, do not give adrenaline. Avoid adrenaline, and you can give chlorpromazine, carbimazole and dexamethasone injections you can give. Next is cardiac arrest. Next condition, cardiac arrest. So cardiac arrest, you know very well, right? So this is a very commonly you see in many places. There will be no pulse, no respiration, no heartbeat. So you have to do CPR, cardiopulmonary resuscitation. So this head tilt and jaw thrust you have to do. Chin lift, you have to lift up and jaw thrust, because you have to give mouth-to-mouth respiration also, and you always make sure there is some pillow below the neck to support the cervical area. Then the cardiac massage, you have to make a fist, right? and then 30:2, 15:1. Those things you know it very well. So now in this cardiac conditions, what has happened? Adrenaline injection 1:1000 you can give. So this is a life-saving drug. Adrenaline is called a life-saving drug. So 1:1000 or 0.5 ml you have to give adrenaline injection. Or hydrocortisone if you are giving 100 mg IV. So in cardiac arrest, CPR has to be done, and then adrenaline and hydrocortisone you can give here. Apart from that, the main drug is sodium bicarbonate. ECG has to be monitored, your PQRS interval. You have to know that whether the ventricles and atriums are working properly or not. In the whole cardiac cycle is proper or not. So for that, ECG monitoring, oxygen therapy, and medical call. So sodium bicarbonate is the drug of choice. Cardiac arrest, you need to give this. Foreign body aspiration, there is no medicine for foreign body aspiration. Just tilt the patient, right? And with your other hand, very vigorously, you have to hit 5 times. And this maneuver is called Helmig's maneuver, right? It will be a sudden one you have to give. So once you hit, there will be the vibrations. So with that vibrations, the foreign body will come out. And hold the second photograph, what you are seeing. You can hold the patient here, and just 5 abdominal thrust needs to be given here. This is for foreign body aspiration. Epileptic patients, whenever a patient develops epilepsy, so stop the procedure first, put the suction so that all secretions will be out. Bite guard you can put, but these days it's contraindicated. You can put some cloth so that the patient will not bite its tongue, so the tongue will not get injured. To calm the patient, diazepam can be given. 2 to 5 mg IV diazepam can be given. This is for epilepsy. See, various conditions, I'm just telling you to the point what needs to be done. Asthmatic patients, patient must be in the sitting position, right? Patient should not be made to lie down because it's already a breathing problem. So the drug of choice here is deriphyllin, hydrocortisone, and salbutamol inhaler can be given here. Anaphylaxis, you gave a local anesthesia injection and suddenly there is rashes developing. So you have to give hydrocortisone, chlorpheniramine maleate, or ephedrine injections can be given here. So hydrocortisone is your life-saving, very powerful, or steroids. This is the one anti-inflammatory action it has. So that will help you to solve many problems. Bradycardia, patient's heartbeat is coming down, give atropine injection IV. Atropine injections IV. Lot of pain, normal painkillers, it's not working, then you can give tramadol injections or tablets. This is opioid analgesics. Okay, so this you can give tramadol or diclofenac sodium. Right. So now I would like to tell how to present your answers in your exams, which is very, very important. So you have 3 hours. So in this 3 hours, you need to dissect the time. How to dissect the time? First of all, let us go question wise. You have got 2 main questions. So each main question, if you write for 20 to 25 minutes, you have got 2 questions, it will become 50 minutes. So in first 15 minutes, your 2 main questions you will be writing. Then you have got 4 short essays. So this 4 short essays, 15 minutes each if you write, 15 into 4, 60 minutes. So what happens now? 50 plus 60, 2 main questions, 50 minutes, and 4 short answers, 60 minutes, 15 into 4. So 110 minutes is over out of 180. You are left with remaining 70 minutes. So in 70 minutes, you should write the short answers. So that is equivalent to 7 minutes per question on an average. So main questions, 25 minutes each, short essay 15 minutes each, short answers 7 minutes each. Now many people do a common mistake. They start with the main question and they keep on writing with a belief that if they present it well, they will get very good score. But towards the end, they lose a lot of marks, right? Towards the end, they don't attempt the questions. And if you don't attempt the question, it is 0. Please understand that. So best thing I suggest you is start with the short essays, then go to the short answers, So by the end of 2 hours, your short essays, that is your 20 marks, and short answers, that is your 30 marks. 50 marks you have already kept attempted and made it safe. So out of 50, you may get 35, something 30, 35 like that. And then you have got last 15 minutes to solve your, answer your main questions. So try that. Okay, so in that way you can score high, because main questions, if it is easy, you know that you will keep on writing and you will miss a lot of time towards the end. So I hope this tip is very useful for you, right? And then when you're attempting the questions, main questions, you should write at least 5 to 6 pages, sides, 5 to 6 sides. Short answers, 3 to 4 sides, and the short essays is 3 to 4 sides, and short answer is 1 page at least. Don't write 4 lines and leave it. So whatever is asked, the questions are very specific. There will be the divisions of the main question, what they want, the same headings you should write it, and then try to answer that. Just you are making a story out of that, no examiner will give you marks. First, what is asked? Classify, clinical features, management. So this headings should be there. If you attempt like this, they will be forced to give you marks for that. Even though answer is not correct, not up to the mark, still, if you have attempted and written something relevant, you will be getting marks for that. So that headings, what is asked in the main question, short essays, that you should maintain and write that. Do not start with the introduction. If it is not required for 3 marks question, you cannot write everything. So just be to the point. And diagrams. For main questions, at least 2 to 3 diagrams should be there. Short essay, 1 or 2 diagrams, and short answer, at least 1 diagram. Because this is oral surgery, it's very simple. If anything is asked on cyst, tumor, it will be there in the maxilla or mandible. Draw the diagram and put the tumor over there. Impactions, again, you can draw the diagram. Orthognathic surgeries, you can draw the diagram. Trauma, you can draw the diagram. So almost in every chapter, what is asked, you can draw the diagram. What is the best time of the day to study? So when research was conducted, and it was found that the best time to study is morning 4 a.m. to 9 a.m. So it depends upon the habit what you are in. If you are studying late night, do not change now. The time is very crucial for you. Don't change your pattern. Just follow the pattern what you are doing. But the best time is 4 a.m. to 9 a.m. Then the second best is evening 7 to 10. And the worst time is 12 to 4 a.m. midnight. But again, this is done on a study. This is a study. There are exceptions. You may be that exception. You may be studying in the late night also. So I request you not to change your schedule. Third question, ASA classification of patients. So this is in general anesthesia. General anesthesia, it comes. Now, please remember this. ASA 1 is a normal healthy patient. Normal patient, healthy patient. But he has a dental problem, but healthy patient. No medical conditions as such. ASA 2. ASA 2 is a patient with mild systemic disease. Mild. What is ASA, first of all? American Society of Anesthesiologists, right? So they, general anesthesia, whether the patient is fit or not for the surgery, we tell that. ASA 2, mild systemic disease. This is a short answer question. ASA 3, a patient with severe systemic disease. I'll give you a mnemonic how to learn this. ASA 4, a patient with severe systemic disease, which is constant threat to life. 5, a moribund patient. And 6, a declared brain dead patient. So now here is the mnemonic. ASA 1 is a normal healthy patient. So just think like a first BDS student who's very happy, energetic. They joined the dental profession. They are extremely cool. They're very happy in the initial days. ASA 1, a normal healthy patient. ASA 2, a patient with mild systemic disease. This is like a second BDS student who has pharmacology to do, right? Who has microbiology to study. So the situation becomes a little pathetic. So a patient with mild systemic disease. First one is healthy, second is mild. ASA 3 is third BDS student. They enter the clinics, right? But HOD will not be targeting them directly because part 2 students, part 1 students are there in between. So ASA 3, a patient with severe systemic disease which is not incapacitating. It is not threatening. It is not spreading, but it is a threat is there because they come under the notice of the staff. ASA 4, that is the final year students, you all. A patient with severe systemic disease, constant threat to life. You have to do cases, you have to be up to the mark, internal marks, everything. So on all your performance based, you will be getting your marks. I'm just giving a link to understand this, that's it. So 1, a normal healthy patient. 2, mild systemic disease. 3, severe systemic disease, but not incapacitating. 4, constant threat to life. Then comes your ASA 5, a moribund patient is not expected to survive without operation. This is the house surgeons, right? You've seen every college, house surgeons are very coolly sitting, right? Like a moribund patient. Even I was like that when I was a student. That is the best phase of the life. Then ASA 6 are the PG students, right? In your college, you would have seen the PG students, right? So this is from Munna Bhai MBBS I have taken. Subject कुछ भी महसूस नहीं कर सकता, he is dead inside. So this is the PG student's life, the plight of every PG student. So with this 1, 2, 3, 4, 5, 6, 3 marks question. Don't write the mnemonics are all there. You need to answer this question. Next question, very commonly asked in the exam, HBO therapy, hyperbaric oxygen therapy. So where is this hyperbaric oxygen therapy given? So basically in osteoradionecrosis and osteomyelitis. So what happens is these patients are taken into a chamber, right? So this is one like chamber. They will be sitting there and there will be a mask or a hood. They have to keep that and inhale. So it's a special room, okay? So the gravity, everything will be little, atmospheric pressure will be little different over there. So hyperbaric oxygen therapy, what happens? Normally, you and me right now, we have got 100% mixture of gases. In this, 71% is nitrogen, oxygen is around 19%. So you and me right now are inhaling 19% of oxygen. But in that room, in the chamber, when the patient inhales, 100% oxygen goes inside. So inhalation of 100% humidified oxygen under pressure happens, 100%. But normally you and me, only 19% out of that we are inhaling. So 5 times more patient is inhaling oxygen, like 5 times more. It's a tsunami of oxygen. Greater than 1 atmospheric pressure. Right now you and me are having atmospheric pressure has 1. But in that room, the atmospheric pressure is 2.4 atmospheric pressure. So oxygen is 5 times more. Atmospheric pressure is 2.5 times more. And then the patient inhales like this for a duration of 90 minutes, 90 minutes. Then the treatment is given for 5 days per week. That is 30 dives, 60 dives. Dive is the unit. So they can ask you in the Viva, what is a dive? 1 dive, right? So dive means 100% oxygen at 2.4 atmospheric pressure for 90 minutes is 1 dive. So this treatment is given 5 days per week for 30-60 dives. Now there is something called as marks protocol. Very, very important. So many times 3 marks this question has come. I'll be explaining that in a very simple way. Please try to register that well. So this osteoradionecrosis HBO therapy, this is expressed in dives. 1 dive 90 minutes, 2.4 atmospheric pressure. The tissue oxygen tension rises to 150 to 250. Normally it is 10 to 15. Tissue oxygen tension in the tissues, the oxygen tension is 10 to 15. But when you inhale, it becomes 150 to 250. So there is a tsunami of oxygen. So because of which, what happens? Oxygen in hypoxic cells, suddenly a new life comes in there. Suddenly they start activated. So there is vascular proliferation and new blood vessels will come. New cellularity of the wound takes place. So when oxygen is given intermittently, see, when someone is waking you up, continuously they will not move you. They will move you little, wait some time and again move you, then you wake up. Similarly, intermittent oxygen is given, the stimulus is given, 100% oxygen. So suddenly the dead cells which are at the verge of dying, they get activated. So vascular proliferation and neocellularity of the wound happens over here. So what is the basic mechanism of action? Enhances healing by direct bacteriostatic effect on microorganisms. So whatever the microorganisms were responsible for osteoradionecrosis, oxygen comes and they have a bacteriostatic action. So three things happen in hyperbaric oxygen. New angiogenesis, new blood vessels are formed. Fibroblastic proliferation and collagen synthesis. The three things happen here. Same thing, it's a photographic representation. The I'll skip. Same thing you can draw from your book also. Now the Marks protocol, the most important part of this question. If you don't write Marks protocol in hyperbaric oxygen therapy, you will not get any marks. So please learn this, what I'm going to tell right now. Right. Now, see, whenever you go to a marriage, whenever any marriage function you go, what is the first thing you get? That is a welcome drink, right? Before meeting the bride or groom or going for eating, you get the welcome drink. So here also, in the Marks protocol, when the patient is diagnosed with osteoradionecrosis or osteomyelitis and normal treatment is not working out, then he has to be given HBO therapy. So when the patient is diagnosed, he is sent to HBO chamber. So his stage 1 patient now. So the patient comes, okay, congratulations. You are not supposed to tell congratulations anyway. So stage 1, initial welcome drink, 30 dives are given. See here, 30 dives is the welcome drink. Stage 1, stage 2, stage 3, stage 3R. In all the 4 stages, the welcome drink is 30 dives, 30. Okay, so patient is diagnosed with osteoradionecrosis. You come to HBO chamber, take 30 dives. What is one dive? 100% oxygen, 90 minutes, 2.4 atmospheric pressure. Right. Now, after giving 30 dives, send the patient home and wait for few weeks and months and then call the patient back again. Initially, you give 30 dives, send the patient back home and you recall the patient. Then check whichever area was problematic, whether healing is taking place or not. If healing is taking place, very good, then take 30 more. Please understand that welcome drink is 30 and in one stage, the maximum dose you can give is only 60. You cannot cross 60. So the 60 is divided into 30-30. That's it. No other formula for this. So initially 30 dives is given. Recall the patient. Improvement is there. Very good. Take your balance 30 because total is 60. Balance 30. Go home. Permanently the treatment is over. Stage 1, patient came. Initially we gave 30. Recall the patient. Not healing. Okay. Take 30. Complete your stage 1. And come to stage 2. Come to stage 2. So stage 1, we did not do anything. We just gave them dives, sent the home, recalled and saw. So stage 2, you do sequestrectomy and primary closure. Very important, you need to write this. Sequestrectomy. What is sequestrum? A dead bone. So the dead bone with the burr and all, you have to give incision flap to take and remove the dead bone. And then suturing you have to do, primary closure. This is done after initial 30 dives. So from stage 1, healing is not there. Patient came to stage 2. Okay, welcome. You take welcome drink. That is 30 dives. After 30 dives, we will do sequestrectomy and primary closure. Send the patient home and after few weeks and months, recall the patient. Then check. If after sequestrectomy and primary closure, it is healing properly, very good. So your balance is 30 more, 30 was welcome drink, remaining 30 to make it 60, take 30, your treatment is permanently closed. So in stage 2, the treatment is solved. That is when it is healing. But after sequestrectomy and primary closure, it is not healing after recalling the patient. You give the patient remaining 30 and bring the patient to stage 3. So I hope you're understanding. Stage 1, you just gave 30 dives, saw the patient and gave remaining 30, brought it to stage 2. Stage 2, you gave 30 dives, you did sequestectomy, primary closure. Because the patient not healing, you bring the patient to stage 3. So stage 3, again, welcome drink, give 30 dives. And after giving the 30 dives, do resection to bleeding, cut that part. If the mandible is not healing, cut that mandible. That's it. You have to sacrifice that part. Resection to bleeding. And give 30 more dives. Totally 60, right? So first 30 you gave, did resection to bleeding, and then give another 30. So that bone is already out of the body. So there is nothing much to heal. So stage 3R becomes reconstruction. R is for reconstruction. So what happens? The bone is removed now. Stage 3, up to stage 3, the patient went. Very serious case it is. So 10 weeks after resection, once the bone is removed, wait for 10 weeks, that is 2.5 months. Call the patient and then you give welcome drink. What is welcome drink? 30 dives. So in this 30 dives, you give 20 dives first, 20. And then you put the plates, whatever reconstruction plate you want to put, you put, suture that area, stabilize it, and then give remaining 10 dives. So 20 dives is initial, put the reconstruction plates, reconstructive surgery is done, give remaining 10 dives, the treatment is permanently closed. So this is your MARX protocol, MARX. Do not get confused, take a screenshot. It is extremely important in your exam. Right. So the time right now is 9:27. I will go till 9:45 and we will wind off there. Then some other day we will plan it up. If it is possible, we will continue that. So I have done 4 questions till now. Another 2 questions I can do. So there was the technical problem. I could not help in that. That is, the team is still working on that. Anyway, so dear students, do you study in any of these postures in the bed? I hope most of you do that, right? But we are not supposed to do. The primary purpose of the bed is to sleep. So when you start very fresh by sitting in a bed, first your position is like this, then you become like this, third like this, fourth like this, and suddenly you will see the book disappears from your hand and you are gone, you are sleeping. So while studying, always you should study facing towards the wall. Please understand that. Never face towards the door and study. If you face towards the door, anyone coming, going, there is a disturbance. Face towards the wall. And in your wall at the eye level, when you sit, put a dot mark. So initial first few seconds, just concentrate on the mark, the dot mark what you kept. So it will just concentrate your energy to one single point. And after that, when you start reading, your concentration level and your learning capability will be much more higher. So do not study in this way. And those people who have a lot of problems in moving here and there, this is one technique you can try out. Just on a funny note, do not practice this. The other thing is, you should always switch off or keep your mobile phones in vibrator mode. Otherwise, one WhatsApp group, hundreds of people are there, any message comes, you get disturbed. So you should be away from all the distractions. Next question, golden hour. Very important question. This comes in the trauma. So whenever, this is a 3 marks question. So whenever there is an accident or injury, what happens? The first 1 hour is called the golden hour. First 1 hour. Who gave this golden hour concept? R. Adams Cowley. That is the name of the person who gave this. R. Adams Cowley. Right. So in this 1 hour, you can do many things. Like you can take the patient to casualty, right? And you can transport the patient. You can do ABCDE, the primary survey, and surgical intervention also can be done in this 1 hour. So this golden hour, whenever there is an accident or injury, you should spend minimum time on the scene. In the roadside accident, spend minimum time and take the patient to the hospital as immediately. And if you're taking in an ambulance, maximum treatment should be given in the ambulance. Now, before the patient reaches the hospital, you have to do, if you're a doctor, paramedical team, you have to do primary survey and secondary survey, which is equivalent to complete assessment. What is this primary and secondary? Primary survey you do at the accident site. You saw the patient, you are checking the airway, A, B, C, D, E. Airway, breathing, circulation, disability, and events related to that. Secondary survey you can do in an ambulance, that is AMPLE, A-M-P-L-E. I'll come to that again now. So primary survey, airway, breathing, circulation, disability, and exposures. Secondary survey, AMPLE, check for allergies. So what happens if the patient is there, you can give 0.5 ml because the patient is taken to hospital. He will be operated there. So definitely before the surgery, pre-anesthetic medications will be given. So you should know which all medicines will be given. You can do a test dose, 0.5 ml you can give, like transdermal injections you can give, subcutaneous you can give, and you can check whether the patient is allergic or not. Mark that area, write the time, and if the area becomes red in color, patient is allergic. So check for allergy. Check the patient's pocket. If any medication, whether diabetes, epileptic, you will come to know a lot of things by just checking the medications. So medications currently used, you should check. This is during the primary survey at the site of accident. Then check for past illness or pregnancy. If the patient is pregnant, left lateral position, you should make the patient lie down, not in supine position, left lateral. Then last meal, very important. What is the significance of last meal? Because whenever you are taking a patient to an OT, operation theater, so patient should be on empty stomach. Because so many muscle relaxants will be there given, patient may pass the stools on the table. So patient should be on empty stomach. Now, if the patient already had a lunch and immediately after that he had an accident, so lavage has to be done, gastric lavage. You have to remove all the contents. So how do you do that lavage? You have studied in pharmacology, enema, right? Evacuation enema, retention enema. So evacuation enema, all the content should be taken out. So primary survey is at the site of accident. Secondary survey is in route to hospital. Now the death in the trauma occurs in, or three types of death are there. First one is non-salvageable. Within seconds the patient dies. Spinal cord twist, gone. Second is salvageable. You can save the patient, but within few minutes to hours it takes place. The death takes place within few minutes to hours. Within 4 or 5 hours by evening, patient dies. The first 10 minutes after an accident is called platinum 10 minutes. And the first 1 hour, our question is the golden hour. And the third type of death is death occurs after weeks because of multiple organ failure. Now, so the golden hour of trauma, this concept is important. So within the first 60 minutes, hour, right? So 60 minutes, primary survey can be done. Stabilization of the patient can be done. Airway, breathing, circulation can be sorted out. So that is your golden hour. 3 marks question, that's it. With the golden hour, one more question comes as triaging. Triaging. It is sorting out the patients based on severity of injury. So you will check A, B, C, D, E, and put a sticker on the patient. Triaging is the term. Sorting out the patient based on the severity of injury. So if a red sticker means immediate attention has to be given. White sticker means 120 minutes are there. So like that, there is one table. Go through that. Next question, management of oral cancers. Very, very important. I will quickly go through this. Right, in next 5 minutes, I will try to wind this management of oral cancers. So first of all, please understand that oral cancers cannot be treated with one single technique. So mechanics is involved, physics is involved, chemistry is involved, biology is involved. So with the mechanics, surgeries we do. Physics, radiotherapy. Chemistry, chemotherapy. And with the biology, immunotherapy. So we are mixing all those things and we are going to treat the cancer. So oral cancer treatment and ameloblastoma tumors, all treatments, these things you can write a little bit of that. So combination therapy means all four amalgamation is there. So we'll go one by one. So we should have all the weapons in our kitty to fire and destroy the tumor cells. So whenever there is a cancer patient, a comprehensive team comes up. So there is a core team of surgeon, pathologist, oncologist, palliative care, community care, nursing, diagnostic, rehabilitation. So the big team comes up and treats the cancer. First one, chemotherapy. Please learn this properly, okay? This is very, very important. Management of oral cancers, chemotherapy. So chemo means chemical, right? So the objective of adding, so you're giving some chemical or drugs you are giving, medicines you are giving to promote why you're giving this chemotherapy, because the initial tumor will reduce in size. You want to reduce the size of the tumor. It's a big tumor. So the objective of adding chemotherapy is to promote initial reduction of the tumor cells. Then chemotherapy for head and neck cancers are there, right? So there will be a temporary reduction in the tumor size, and then you can go for a radiotherapy and the surgery also. So what is chemotherapy? Introduction of the chemicals to reduce the size of the tumor. Now there are classification for this based on biochemical pathway. In what pathway it will go inside the tumor cell and it will destroy the cell. So based on biochemical pathway that lead to cell replication or DNA synthesis, you have got alkylating agents, antimetabolites. Take a screenshot, you can learn it later. So this is based on biochemical pathway. Then you've got other things also. You've got anti-tumor antibiotics, mitotic inhibitors, miscellaneous. So what they will do, they will go into the cancer cells, the antibiotics, and it will prevent it from functioning normally. It will alter the DNA. So normally the tumor cell will not work and it will die up. So this chemotherapy, there are 6 types of chemotherapy: induction, concurrent, adjuvant, palliative, intralesional, topical. Just the names are enough. You don't have to go into much depth of it. So chemotherapy means introduction of the chemicals, right? Or the medicines, you can call it. You have got a classification for that, and these are 6 types are there. So complications of chemotherapy, you will see that cancer patients, they will become bald if they are under the treatment. So alopecia, bone marrow suppression, mucositis, the list goes on. So these are the complications. So when the dental patient is undergoing chemotherapy, you have to finish all the comprehensive care of the patient, like extractions, restorations, oral hygiene, scaling, everything you need to finish before chemotherapy. And when the patient is undergoing chemotherapy, then mouthwash you should give, right? Lidocaine, if some cuts are there, pains are there, lidocaine you can use, and flucosanol for candidiasis. Dentures should be cleaned periodically, and this all precautions you need to take during the treatment. So before the chemotherapy, during the chemotherapy. After chemotherapy, oral hygiene index should be checked, and patient should be checked whether there is anemia or not, bleeding tendencies are there or not, infections are there or not. So very clear, chemotherapy, very simple. Next is radiotherapy. So management of cancer, first is chemotherapy over, now radiotherapy. So radiotherapy means some radiations we are giving to the patient. Purpose is curative and palliative. Curative and palliative, right? So you have to cure or just take care of the patient. So basically an external beam radiation will come from outside. That is the teletherapy, what we call it. So here 2 terms will come, teletherapy and brachytherapy. So we have gamma rays and X-rays. They represent photons, whereas X-rays are man-made sources. So these are the radiations, X-rays, gamma rays. So the radiation sources, from where this radiation comes, that is the machine. That machine is made up of, they have the normal physics over there, low kV volt radiations, external, that is electron beam therapy, that is teletherapy. So these are the radiation sources. Now this radiotherapy can be given by 2 types. One is from outside, external beam radiation, like a telephone. Someone else is calling you, right? So that is telephone. So it is like teletherapy from outside, from somewhere else it is coming. So from a machine it is coming, that is called external beam radiation or teletherapy. Then the second method is brachytherapy. Brachytherapy means the radiation source, you will give an incision, put it inside the tumor mass and suture that area from outside. So slowly, it will be like locally acting. The radiations will be there. That is brachytherapy. So this is teletherapy from external beam radiations are given. Brachytherapy means you are putting inside like an implant. So interstitial or intracavitary implants are used over here. So what is the source of radiation? Radium 226 and iridium 192. These are the ones which are radium and iridium are the sources of brachytherapy. These are implanted into the patient. So with an injection you can do, or loop or catheters you can use to introduce this to the patient. So what happens once it is there inside the mass, tumor mass, continuous radiations are given over there. So based on the staging, T1 and T2 stage, they will respond well to radiations or surgery. T3 and T4, very serious case, only to the radiation, they will respond very poorly. So based on stages, this is the one. Recent advances, this even if you don't write, no problem. These are the recent advances in radiotherapy. Now coming to the complications of radiotherapy, nausea, vomiting in the first week. Second week, nausea, vomiting plus mucositis and taste change will have, metallic taste will come. And third week, all the above plus dry mouth will come. Apart from hair loss, everything else there. So just an idea I'm giving you where chemotherapy, radiotherapy, you need to explain. So again, what precautions you should take during and after or during the procedure of radiotherapy. Before the treatment, all the comprehensive care should be done. Extraction, restoration, scaling, filling should be done at least 2 weeks before. Extraction has to be done 2 weeks before, it has to be done so that everything will be fine. Then comes during the treatment. During the treatment, you have to make sure patient will have dry mouth, right? So patient should be discouraged of smoking and drinking, and mucosal and salivary gland protection should be done. Mucositis inflammation will be there, you have to treat that. Antifungal treatment should be done, and saliva will be reduced, so salivary substitutes has to be given over there. So these are the complications, accordingly you need to treat. After entire process of radiotherapy, oral hygiene instructions, again you have to check, and scaling if it is required needs to be done. Dentures can be given 4 to 6 weeks later. So all these things are after the treatment. If extractions during the radiation therapy is going on and is unavoidable, then you have to do it very carefully. Prophylactic antibiotics should be given 2 days prior and continue for almost 4 weeks. Even parenteral antibiotics also needs to be given, right? Even HBO therapy can be given before and after the extraction, depending upon the severity of the area, right? So this is one. So first one is your chemotherapy, second is radio, third is surgical. So surgery, what we do in surgery, it is you take out the whole mass, send for biopsy. So staging and grading you have to do, removing of the primary disease, then metastatic disease, lymph nodes dissection also you should do, palliation, prevention and reconstruction. So these are the 6 steps or 6 objectives of doing a surgery. This thing is very important, you should write this. So surgery includes, first is resection of the primary tumor. After removing the tumor, you can't stop over there, you have to do lymph node dissections also, because metastasis would have happened. And then if you have removed some mass, you have to reconstruct that also. So these are the 3 steps in surgery which you need to do. So first one, this is what you are supposed to write. Even for an ameloblastoma case, if your main question comes on ameloblastoma, the 5th and 6th step is very, very important. So we'll start with enucleation, curettage, marsupialization, recountering, resection with and without continuity defect. Even for the cyst question. This holds valid, right? Resection with or without continuity defect. If it is involving the lower border of the mandible, it is with continuity defect. If it is not involving, without continuity defect. So this steps, I hope you are very clear with this. It's a simple thing. I'm just refreshing it. So surgery is maxillectomy, mandibulectomy. Now, what is the incision given for maxillectomy? A very common question. This is Viva question. Weber-Ferguson incision. Weber, W-E-B-E-R. Weber Ferguson, F-E-R-G-U-S-S-I-O-N. Weber-Ferguson incision is for maxillectomy. Then hemimandibulectomy can be done, glossectomy, radical neck dissection, and Mohs procedure. So these are the levels of lymph node. First of all, the excision of the tumor mass you will write along with the cervical lymph node dissection. Level 1, this photograph you can take, it's very easy. Level 1 is your submandibular region. Level 2, this is your jugular vein. So upper part, upper jugular vein is level 2. Level 3 is middle jugular vein. Level 4 is lower jugular vein. Level 5 is posterior compartment. Level 6 is anterior compartment. So these are the 6 levels of lymph nodes. Based on your severity, you need to do a surgery and remove this lymph nodes also. So now in the neck dissections, when you are removing that, 2 terms come: radical neck dissection, or it is called RND, radical neck dissection. Radical means what? Very aggressive. So in the neck, you will remove the spinal accessory nerve, right? You will remove the muscle also, sternocleidomastoid muscle, internal jugular vein. You remove everything. So what happens? Even for a small tumor, you remove everything. The whole life patient will be having a bent neck, wry neck, what we call it. So that later the doctors found out that it is not required. That much extensive surgery is not required. So modified radical neck dissection was carried out. So that is modified. You will just go to that area and pick what is diseased. So you have got MRND, modified radical neck dissection. Then you have got something called selective neck dissection, supraomohyoid level, different levels, anterior, posterior, lateral, anterior compartment, extended radical neck dissection. You need to do that. So 3 incisions what are given commonly for neck dissections are McPhee's incision, triradiate, and Hayes-Martin. This photograph I took from Neelima Anil book, right? So these are the 3 common incisions. Then once your chemotherapy is over, radiotherapy is over, surgery is over, then you have to do a reconstruction. So reconstruction to give the function back to the patient. So this is how the reconstruction, delayed reconstructions are done. Reconstruction plates are fixed, articulation is done, and then the whole area is built up over there. Right. So it's 49 now. I have done 6 questions because we lost half an hour, first half an hour to 40 minutes we lost in the initial stages. It will be too late. Right. The other questions, what I will do is, I will just put a voice note in your WhatsApp group. That is Lincoln's Highway and some other questions are there. I will put a note in your WhatsApp group. Right. So dear students, as your exams are there, now you have got around 13 days. Right. 13 days means today is 3rd, 16th is the date, 17th onwards you are having examinations. So this 13 days, what you can do is 3 days you take it out. That is for the first subject you will study. I think that is prosto, I think, for you. So 10 days you have got. So this 10 days you can plan in 2 different ways. This is as per me. You can plan in your way also. So what you can do is, you can divide into 10 days are there, 2 techniques. First technique, 5 days, 5 days. So in this 5 days, first 5 days, you do subject 4 and subject 3 in this 2 days, first phase, the first 5 days. That is early morning till lunchtime, you will do subject 1 or subject 4, that is oral surgery. And post lunch till night, you will do subject 3, conservative or whichever pedo I think you have. This you will go for 5 days. So what will happen with 5 days? Your first 5 days, 2 subjects is over. Next 5 days, you will do subject 2 and subject 1. Because the first subject is, you're going to write in the very first. So within 10 days, your all 4 subjects will be over, and subject 1 you are doing towards the end. The 5 days you will do, plus you will get additional 3 days. Because out of 13 days, I am counting only 10 days. 10 days divided into 5 days, 5 days. This is one technique. The second technique is you can divide, or you can take 12 days, right? 12 days. So 4 3s are 12. So you will divide into 3, 6, 9, 12. Like in a days of 3 days, you will have round 1 3 days, round 2 second 3 days, round 3 third 3 days, and round 4 the last 3 days. So here what you can do is the subject 1 you can read now the first 3 days, subject 2 the second 3 days, subject 3 the third, and subject 4 the last round. And again you have after that 3 more days which you can do the first subject. I hope it is clear. If it is not clear, because time is too late now, I'll put it in the WhatsApp group. Okay, so tried our best. DSA and Eden2 tried their best to give the maximum, but because of technical reasons, which is not in our control, right? It can happen to anyone. Tried our best to give you, and all the important questions I will be posting in the group, subject chapter wise regarding oral surgery. So you will go through those questions. It will help tremendously. So the major key is you should attempt all the questions. The people who don't attempt are the ones who narrowly miss out in the exams. So go with a positive feeling. You are going to study for the very last phase in your life. After this, it is not at all mandatory studies. You should be 100% active, right? Because you cannot relive your life. Life is only once. So go ahead and give your best shot. So wishing you all the very best. Okay. Thank you so much. Any doubts, please put it in the WhatsApp group. We will see it there. Thank you. Thank you so much. Thank you.
Thank you, sir, for your valuable time.
Feedback in the WhatsApp group. Please give your feedback.